Um, Thank you all for coming. I think we'll have some people filtering in. Part-time faculty, make sure you sign the list over there. And for those of you that don't know me, I'm Bob Myers. I'm not? No, you're right, I'm not. No, that's right, I'm not him anymore. I'm Tom Pleshek. I'm the new director of the Performance Wellness Institute, PWI, and welcome to our first big event of this year. We're going to have another one in April. I don't know the exact date, and that's going to be on hearing and hearing health, so please come to that one. Yeah, everybody goes, what? We have a couple of audiologists from Mass Eye and Ear, and a specialist in headphone problems and earbud problems from Children's Hospital. Hopefully they will be attending. So hopefully all of you got the little program that tells you what's happening, and you can read on it the credentials of Dr. Dolan, and they're up here. And when we invited him to come, we sent him a list of questions to address in his talk, and I think he's going to deal with these quite well. So the first one was, what is a healthy hand? And the next one, what are the behaviors or habits that lead to ailments? Can you help us identify poor habits of the hand, arm that lead to strain, pain, etc.? What are your views on overuse versus misuse? Have you seen patients overcome ailments by retraining? So please give a welcome to Dr. Martin Dolan.
Thanks. Afternoon, everybody. How are you today? Thank you for that introduction, and I want to thank the faculty and staff of the Berkeley Professional Performance Division, and as well as the Performance Wellness Institute for inviting me to be here. And I also wanted to thank Matt Marvulio, who I think, oh, there he is. Hey, Matt, how are you? For inviting me to come talk today. It's really a exciting thing for me to be able to come talk at Berkeley. You know, it's really cool to be at Berkeley. To be honest with you, I wish I could be speaking to you in the capacity of a musician instead of a doctor, because I guess you could call me sort of a frustrated musician. But I am a musician and I still play, and so it's really cool to be at Berkeley. And it's an amazing place to think about all the amazing musicians who've come through here before and who will continue to come through these doors. It's pretty awe-inspiring. And some of my favorite musicians are alums of Berkeley. So thank you for inviting me to come talk to you today. A little bit of background and before I get into sort of the nitty-gritty about the hand stuff, a little background about me. I do have a background in music to a degree. I was and am a drummer. And so I started at a pretty young age. I did some formal sort of training as a jazz drummer, and then kind of sort of morphed into doing more rock and roll drumming, and I continued to do that well through my adult life. This is a picture of me from years ago when I had more hair playing the drums. It's one of my favorite pictures. I don't look like that anymore. This is a picture of me when I was a lot younger. That's when I had less hair again. That's when I started playing at a young age. So. No, in fact, that's not me. I'm sure a lot of you have seen this picture around. It's a very cute picture, but it's not me. But, you know, being a drummer, sometimes it's hard to get respect as a drummer. And so you have to fight for, I don't know if there's any drummers here. So anyway, I was a drummer, but I did a lot of other things in music. I played a little guitar, I played a little piano. And in my adult life as a hand doctor, it's been really helpful because playing the instruments yourself or being trained on the instruments is really, it's the only way you can really understand the mechanics of how you play, right? So when a patient comes to me and says, I'm having trouble playing a B-flat bar chord, or I can't play match grip, I have to play traditional grip with my drumsticks, or my range isn't what it is, hopefully I have some understanding, more so than someone who doesn't play music would. So that's been helpful for me. The transition from being a drummer to being an orthopedic surgeon, I guess, is sort of logical. Some people say there's a lot of similarities, which I guess makes sense. I can remember one of my colleagues who was in what you might call a more cerebral subspecialty of medicine said to me, "You orthopedic surgeons, all you do is hit things." And so I said, well, at first I was a little insulted, and I said, well, that I guess makes sense. Yeah, it's kind of true. And it sort of jived with my background. But and you know, the transition from being a drummer into becoming an orthopedic surgeon wasn't always entirely seamless. I can remember a time when I was in my residency, so I was training to do surgery in a hospital in New York, and it's very conservative. You know, the surgical mentality is, you know, very military, have a short haircut and, you know, your tie buttoned up tight. And I had very long hair because I was still playing music, and that's how I liked wearing my hair and stuff. So one of the older surgeons came up to me and said, he was from Texas, and he put his arm around me and he said, "Son, there's only two kinds of haircuts in this hospital, short and bald." So I said, okay. So I shaved my head. So I guess that was the inner musician in me coming out. So anyway, time goes on, and now I'm an orthopedic surgeon specializing in hand surgery. And I definitely have an interest in taking care of musicians because of my background. And I do see a lot of musicians from the area, both from Berkeley and from some of the other surrounding institutions, and I enjoy that. So much to the point that we are actually currently, I work at Harvard Vanguard, which is over in Kenmore Square, not far from here. And so I see patients there, but we're actually in the process of trying to start a musicians clinic, and we're doing that, in fact. Not trying, but we are, and that'll be starting soon. The idea is to have a group of clinicians, doctors, nurses, therapists, who have a background in music, who have an interest in music, and know sort of the ins and outs of taking care of musicians, and also to sort of fast-track musicians who need to be evaluated quickly, in a way so that we can get them in a timely fashion to be treated appropriately. So that's something we're excited about, is our musicians clinic that we're working on up the street, and hopefully at some point all of you will be able to take advantage of that. I want to make a quick plug for an organization I'm a part of. It's called the Performing Arts Medicine Association, which is a really good organization that's made up of, it's primarily healthcare providers, but not only healthcare providers, doctors, nurses, therapists who are interested in the performing arts. It's not just music, it's also dance and theater, but primarily musicians. And it's actually a really good resource. They have a very good website if you want to check into that. It's up there, pama.org. And it's a good resource and a good organization I'm proud to be a part of. So some of the questions that were mentioned earlier, we're going to talk about that a little bit, but how we're going to kind of focus it in my part of this program, we're going to talk a little bit more about the common conditions that I see in musicians, okay, and how I evaluate them, how I treat them, and then we'll talk a little bit about prevention. But the later part of the program is really going to focus more on prevention and techniques we can use to avoid these conditions from developing. So common hand conditions that I see in my office in musicians, far and away the most common is overuse. Okay, so and these are sort of listed in order of how common or the frequency they see them. Overuse injuries, and I'm going to talk more specifically about these. Overuse injuries is by far and away number one. The second would be traumatic injuries. And unfortunately, we do use our hands to interact with our environment, and so they're at great risk for injury. And so we do see a lot of injuries in musicians, and we have to be able to deal with them appropriately to get you back to function as quickly as possible. Neurological disorders, there's a broad range of those, but there's a few that are very common, again, and that we see, and I'm going to touch upon some of those that we see in musicians. Cervical or postural, which relates to the neck, and postural is a very common condition. It's not a hand condition per se, but it can very much affect how your hands work. So it's something to talk about that's important. We'll talk about that briefly. And then the last part, which is almost more out of interest, but factitious or somatoform disorders, which actually fall more into a psychiatric category. And we do see these. They're much less common than organic or injury-related conditions, but we do see them, and we have to be able to diagnose them and treat them appropriately. So overuse injuries, but far and away the most common. Tendinitis is going to be the most common far away. Trigger finger is something that we see, and some of you may have heard of that. And then repetitive strain injury. And repetitive strain injury is the one I want to talk about or spend a little bit more time on, because I think it is poorly understood. We're seeing it at a much more, an increasing rate, a much higher frequency. And I've seen lots of musicians who have this. So we're going to talk about that in a little more detail in a bit. So tendinitis, I'm sure you've all heard of it. You know, tendinitis literally means inflammation of the tendons. Okay, the tendons, you know, if you look at your hand, the back of your hand, those bands on the back of your hand, the tendons attach the muscles to the bones. Okay, so they facilitate motion. They're like the strings of a marionette, right? They move the fingers, and so function of the tendons is really critical. But as those tendons move, they glide through a sheath. That sheath has fluid in it, and it has to glide efficiently. And if it's gliding too frequently and you can't maintain efficient lubrication, there's a friction phenomenon. And when you have a friction phenomenon, it generates inflammation, and inflammation generates pain. And you can sort of see that schematic on the upper right there. It's really the sheath of the tendon that gets inflamed. It's not the tendon itself. It's the synovium, which is the cells that line the sheath, and that become swollen and red and hot and painful. And that's far and away the most common thing I'll see in musicians is just straightforward tendinitis. The good news about tendinitis is that it's treatable. It's very treatable. A common form of tendinitis is something called the Quervain's tendinitis. I don't know if any of you guys have heard of this. It involves the radial side of the wrist or at the base of the thumb. There's two big tendons that run through there, and they frequently get inflamed just from repetitive thumb motion. That's all it takes, is doing this and this. And it becomes painful and hot. It can be very debilitating. It can be very debilitating. Another common one is lateral epicondylitis or tennis elbow. I see this a lot. This can be in woodwind players. It can be in guitarists, pianists. The people I see this most commonly in, who are musicians, however, is people who have to lift and move heavy equipment. Okay, so if you're not fortunate enough to have roadies and you got to pack your drum kit, which I had to do every time and hated, and you're carrying those heavy things, you're at risk for getting tendinitis in your elbow. Very common thing. And tennis elbow is kind of a stupid name because I'd say less than 5% of people who I treat with this condition ever play tennis. And a lot of them are musicians. Okay, so that would be another common example of tendinitis. Like, as I was saying, the treatments for tendinitis are generally pretty effective. And I highlighted the one on the top. The key is rest. Okay, so tendinitis, which is an overused thing, is not the kind of thing that you play through pain. There's some conditions where they say, well, you got to work through the pain, and the only one, no pain, no gain kind of thing. It's not the case for tendinitis. You need to rest. You need to rest. And the hardest thing I've come across with dedicated musicians with their practice schedules and rehearsal schedules is that they don't want to take any time off, which I understand. But the key is really resting it, modifying your activity, modifying your rehearsal schedule in ways to let this heal, let it recover. And we're going to talk more about prevention later in the program. But that's the single most important thing I tell musicians when they come in. They'll ask me, well, what medication can I take, or what therapy can I do? And those things are important, but it's modifying your activity and resting what really is most important. We do splinting, and there's some pictures up there. You can immobilize the thumb, allow it to rest. Therapy, working with occupational therapists. And I specified OT because hand therapy is traditionally done by occupational therapists, not physical therapists. That's sort of an area that generates a little bit of confusion. That's sort of evolved over the years, and it's a little bit of just evolution of the specialties. But certified hand therapists are occupational therapists, not physical therapists. So I have a bias. If you're going to get therapy, go to a certified hand therapist who's an occupational therapist. There are physical therapists who work on hands and arms and elbows, but my preference would be for an occupational therapist. Medication, anti-inflammatory medications, I put a leave up there, but they're all pretty much the same. Ibuprofen, Motrin, Advil, they're good preventative and treatment medications for tendinitis. Tylenol is not an anti-inflammatory. So I don't know if most people know that. Tylenol is actually a painkiller, but it's not an anti-inflammatory. So it can be helpful if you're having pain. But for inflammatory conditions like this, anti-inflammatories are better. Ibuprofen, Aleve, Motrin, that kind of stuff. We do cortisone shots. You hear people say cortisone. You hear that word thrown around a lot. Cortisone refers to corticosteroids. Corticosteroids are basically a very strong, long-acting anti-inflammatory medication. It does the same thing that Motrin, Advil, or ibuprofen would do, but it's much stronger, it's much longer acting, and you can locally administer it. So you can inject it around a tendon, and it can provide long-term relief. There's also a perception that it's dangerous or harmful. People say you got to be really careful with cortisone, and there's this sort of this fear about it, which I think is not really justified. I think if it's used in moderation, it's very safe, very effective, and it can provide a lot of relief. It shouldn't be your only treatment, but it can be very helpful. So something to consider when people say, consider a cortisone shot. Rarely do we have to do surgery for tendonitis. In really severe cases that aren't responding, we'll do surgery, but that's rare. Trigger finger. This is another name that you'll hear thrown around in the hand surgery world. Musicians get this a lot. Trigger finger is another example of tendonitis, but it's a little different in that it involves the tendons that bend your finger, okay? And the tendon gets swollen, and you can sort of see in this picture in the bottom right here, the tendon actually swells, and it gets so swollen to the point that it can't glide through its sheath system efficiently, and so it causes pain, it causes swelling in the early stages, and then as it progresses, it starts causing clicking. So patients will say, my finger, when I bend it, it's catching, it's clicking. I feel a clicking sensation. It may feel like it's the knuckle, but it's in fact the tendon. It can even catch and get stuck down like this. So you can see the picture there. And you have to manually use your other hand to pop it out. It's not a serious condition, but it can be really limiting for musicians. Very common, and on an average day, I'll see 5 to 10 people a day with trigger finger. So it's super common. Fortunately, it's easily treated. It does not respond to therapy or splinting, but cortisone shots will cure it half the time. And if this cortisone doesn't do it, there's a very minor surgery we do to correct it. So trigger finger, fortunately, is an easy problem. If I see a musician who comes in and they're worried about arthritis or something more serious, and I realize it's a trigger finger, I'm usually happy because I know I can make them better. So that's good news. But you'll see this very commonly. I want to spend a little more time on this diagnosis, repetitive strain injury, or RSI. This diagnosis really didn't exist 10 to 15 years ago, at least this term. And so it's a relatively new diagnosis. I'm seeing it at significantly increasing rates recently, and the data supports that the rates are increasing. The demographic or the group of patients that we see tend to be college-age students, typically musicians, okay? And we don't really know why that is, but it probably has to do with the fact that you're practicing and rehearsing with your musical instrument, but you're also spending tons of time on the computer to get your work done, and when you're not doing either of those, you're texting. So there's probably, the combination of those two, and that's why I thought this picture was funny, because she's playing the guitar and texting at the same time. This is what we're seeing, and that's the demographic. So it's a kind of a new phenomenon, but it's very real. It's hard to diagnose. The patients who have this typically come in with sort of vague complaints. They say, I'm having pain in both my arms. It kind of moves around. It's with activity, with the computer or rehearsing. I'm having some tingling in it, but again, it kind of moves around, and I can't really localize it, but it can be painful. And so it's sort of vague. And so for that reason, I think previously it got poo-pooed. People would say, it's not real, or don't worry about it. But it's a very, very real phenomenon. I see it. It has a very clear presentation. I believe that it's real. There are some studies that suggest there are links that relate to stress too. If you're in a high stress situation, as students are, they're trying to get their work done, get their rehearsals, done. There's probably a component of that too, but it's an overuse phenomenon. It's very real. I believe that it's real. Some people will attest that there's a psychiatric component to it. I haven't found that to be the case. It's too consistent and reproducible.
How much overlap is there with thoracic outlet syndrome?
Not much at all, actually, but it can be difficult to differentiate the two. So there's overlap clinically in terms of the symptoms, absolutely, but the cause is clearly very different. I'm going to talk a little bit about thoracic outlet syndrome a little later, but it's a very good question. A lot of these conditions will overlap, and one thing I was going to say about RSI is that there's no test for it. You can't do a test. You can't do an X-ray, an MRI, a nerve test. You can't. There's nothing you can do to diagnose RSI. So it's what we call a diagnosis of exclusion, which means we rule out other things that might be causing your symptoms, and if we can't identify a source, we may end at RSI. But so that's frustrating when you don't have a test to say. So thoracic outlet syndrome is a condition I'll mention briefly in a bit, where the symptoms can overlap. So we have to rule these things out, carpal tunnel syndrome and other things. If we can rule those out, then oftentimes we end up with a diagnosis of RSI. But it is a very real phenomenon. It's not just because we couldn't figure out what's going on. It's a very real entity, I believe. So this, to me, is of the few subjects that I've kind of was going to talk about today. I think this is, if you're going to leave here, one of the things to keep in mind. This repetitive strain injury is very real, and it's something that we're seeing, at an increasing rate. So something to keep in mind. The treatment for repetitive strain injury, again, is it's activity modification, changing your rehearsal program, changing your activities, therapy, rest, things like that. There's no other real magic bullet for repetitive strain. That's the other hard part, is that it's frustrating, because I have to sometimes say to my patients who are musicians, you can't practice for X amount of time. You're gonna have to take, and it's a hard sell sometimes. So I don't want to spend too much time on traumatic injuries, but I think it's important to talk about it, because other than overuse, this would be the most common thing that I see in my office with musicians. Other than being musicians, you're out exploring the world, you're playing sports, you're doing things, you're tripping and falling, you're being normal people. And so these things happen. We use our hands to interact with our environment the most, and so the hands are very vulnerable. Anything from fractures, sprains, lacerations of the tendons that bend your fingers, lacerations of the nerves that give sensitivity to your fingers, or even amputations are all things I've seen in musicians. And so you have to manage them, very specifically, oriented towards return to play. Same way you would manage an athlete. Your approach is, when can I get this person back to their, full level of participation? The term fractures, for some reason, it seems to me the term fracture has come to imply a little crack or a non-displaced fracture. Fracture means anything broken. A broken bone is a fracture, whether it's a little hairline or whether it's completely out of place. That's what a fracture is, just for terminology perspective. There's all kinds of fractures. It's beyond the scope of this lecture, but they can range from very minor to very serious, and they're managed accordingly. They can sometimes have minimal effect on your, a musician. Otherwise, they can be potentially career-ending. So we're not going to spend too much time on talking about all the different kinds of fractures. The treatments for fractures will vary based on the severity and the extent of it. Casting is very common. Cast is on the left side there. A cast implies that it can't be removed. The old-fashioned casts are made with plaster. The newer casts are made from fiberglass. They're lighter. They're more comfortable. We even have waterproof casts, so if you have to go in a cast, they can sometimes be waterproof, so you can get in a pool if it's the summertime or go to the beach or whatever. Splints, which is the other picture, imply that they are not circumferential. So a splint doesn't go all the way around, and it's typically removable. Okay, so they're oftentimes either made by a therapist or they're kind of off-the-shelf prefabricated. The ideal splints are made by a therapist because they're custom made and molded to your hand, so they fit better than anything else. It's a plastic that melts, they mold it, and then it sets. So it's like a cast, but it's plastic and it's removable. So we use splints a lot, and that's the difference between a cast and a splint. A little bit on the surgical techniques. I'm not going to bore you with too much detail, but just so you know how we manage fractures. Broken fingers, I see them in musicians all the time. In more simple fractures, we oftentimes will do what's called pin fixation. So people say, I got pins in my hand. Well, what does that mean? I got pins. What we can often do is get the fracture lined up using an x-ray machine, and then we put in these pins. And you can see them in the bottom right there. That's what the pins look like. They're just a thin, sharp piece of stainless steel. And on the upper left picture, there's a drill. And you can just put that in through the skin and actually hold the pieces of the bone together. The pins stay in temporarily. They usually get pulled out in about 4 weeks, and then you can start therapy. So that's one of the techniques we'll use to fix fractures, pin fixation. In more serious fractures, we fix the fractures with internal implants, plates and screws. We put the pieces back together and then put combination of plates and screws to hold things together. And here's some examples of what that might look like for fractures. Just moving on to sprains. I want to spend a little more time on sprains because I think that this is, in my experience, has given me some of the most trouble I've had with musicians is sprains. More so than fractures, more so than some of these other injuries. The reason for that is because we all have sprained our fingers. I jammed my finger. Catching a football, you fell, you jammed it against the wall. The finger gets a little swollen. Not a big deal. Many of them are not a big deal, okay? But some of them really are, okay? A significant sprain to your finger can be a real problem. And the reason it can be a real problem is because of stiffness. Okay, stiffness, stiffness, stiffness. This is when we're learning to be hand specialists. This is what we learn about. The biggest problem with these traumatic injuries to your fingers is stiffness, right? You can't bend the finger. You can't, or you have trouble straightening it out. Obviously, for a musician, that is a big deal, okay? And some of the worst outcomes I've seen in musicians who have relatively minor injuries is they have a sprain that's a moderate sprain, and they go see somebody who's not a hand specialist, and they put them in a splint. And they put the splint on. And then they wear the splint for 3 weeks, and they never get referred to see a hand doctor, and they haven't moved their finger in 3 weeks. And they never really move their finger well again, only because they were in a splint for too long. Okay, so our philosophy with fingers and hands, really in general, is get it moving at the earliest safe moment that we can do it. So my advice is, if you've jammed your finger and you have a swollen knuckle, get it evaluated. Get an x-ray, make sure there's nothing broken. If there's nothing broken, we're going to start you in therapy that day, within 3 to 5 days. So getting it moving is absolutely critical. I've seen disasters for people who wear a simple sprain. They wear a splint for 3 to 4 weeks, and they're permanently changed by it. So that's an important take-home message, is get these sprains evaluated. For the average individual, it may not be as critical. For a musician, absolutely critical. Buddy taping, you can see a picture. You hear people talk about buddy taping. This is typically how we treat sprains. It seems archaic, but it is actually genius. You just tape the sprained finger to the next finger. It provides protection and splinting, but it allows you to bend and move. So it's perfect. It's a dynamic moving splint. So buddy taping is great. It allows you to get moving within a couple of days. These finger sprains can take months, 3 to 6 months, even longer to calm down and not be painful and swollen. Never let anybody immobilize your finger in a splint more than 3 days unless they're a hand specialist. Okay? It's too long. If it's a fracture, you may have to. You may be immobilized for 4 weeks, but you have to. But if there's no fracture, we're moving you. So that's a critical point. Tendon lacerations, this typically happens. The most common story is people will say, I was cutting an avocado or I was cutting a bagel. And they slip with the knife. And unfortunately, the knife goes and cuts the tendon. It bends your finger. These are very serious injuries. Okay, they're very serious injuries for anybody, specifically musicians. The reason for that is because these tendons, even if we repair them, and they need to be repaired, and you fix them with surgery, the scar tissue and the stiffness, again, stiffness is what we're fighting, is very serious. It changes a little bit where the tendon is, whether it's in your palm or on the back of your hand, but in general, these are serious issues for a musician. Yeah.
Dr. Dolan?
Yep.
Before you go too much into that, I wanted to know if you could please, about the spraining. Could you talk about heat versus cold?
Sure, absolutely. That's a good question. I get that question all the time. The question was, the role of heat or cold therapy in treating sprains. They both have a role. If you look at what heat and ice do, it's fairly simple. They affect the blood circulation to the digit, right? So when you apply heat, the blood vessels open up, they dilate, it increases circulation. Ice has the opposite effect. It causes the vessels to constrict and it decreases blood flow to the area. So that's useful. They're both useful in a way. In the setting of an acute injury, just happened, ice, absolutely ice, because you're trying to decrease the inflammatory response, which will last for 24 to 48 hours. So absolutely ice, no heat. Heat is just going to contribute to swelling. After you get through that acute phase, though, there is a role for heat. And heat, by dilating those blood vessels, will bring in healing factors. There's proteins and cytokines and all these little guys that live in the blood that promote healing that have to get to the injury site to allow it to heal. So it also has a loosening effect on the tissue. So as a simple rule, I tell people in the acute phase for the first 2 to 3 days, ice only. After that, it's heat before, ice after. Heat before activity, ice after. The heat gets you going, gets you loose, brings in those good healing factors. You do your therapy, you do your rehearsal, and you lose, and then you're sore, and you ice it afterwards. So that's sort of my general protocol. In the beginning, ice only, then heat before, ice after. It's a very good question. So anything else about sprains before I talk a little bit about the tendon injuries? No? Okay. So the tendon lacerations, again, these are serious injuries. They need to be evaluated promptly by a hand specialist and really a hand surgeon. They're always going to need to be repaired if they're complete lacerations. And the recovery is protracted. You're looking at 4 to 6 months of full recovery if you have a tendon laceration. If it's on the palmar side of your hand, it's inherently worse. But these need to be treated right away and treated aggressively with surgery. There's a lot of therapy that goes in. You'll get to know your hand therapist very well. And unfortunately, this is, of all the things that I'm mentioning today, this is probably one of our least effectively treated problems. The outcomes of these flexor tendons on this side, even when they're sewn up and repaired, the outcomes are lousy. The techniques are really not that great, and these are very, very serious injuries. So be careful if you're going to be using a knife to cut a bagel or an avocado. It's always avocados. There's something about avocados. Just be careful with those. And bagels. Nerve lacerations. So you have sensory nerves in your fingers. There's one on each side, and they provide the sensitivity to the tips of your fingers. These are frequently cut, same way as the tendons. It's a slip with a knife, typically. And if they're cut, they're not going to heal. You're going to have permanent numbness beyond the point where the nerve is cut. Okay, so they generally need to be repaired. In your fingers, the nerves only provide sensitivity, sense of touch. They don't provide any motor function. They don't affect your ability to move. So if you cut a nerve in your finger, you're not going to lose motion. You're not going to lose fluidity in your fingers, but you will lose fine sensitivity, which can be very significant for feeling your instrument. So it's a very significant thing. We generally repair them with surgery. If you cut a nerve higher up in your wrist, for example, at that point the nerves do provide motor and sensory function. And so those can be very serious injuries because it can affect your ability to move your hand in addition to have sensitivity. So generally any kind of nerve injury in a musician gets repaired. It usually means surgery. You're using a microscope. You can see a picture of it there where you're on a microscopic level sewing the nerve back together and hoping that it will recover. They often do. Sometimes they don't recover even with surgery. So you can have permanent loss. We oftentimes see nerve injuries with tendons that you get the tendon and the nerve at the same time. So we have to fix the tendon and the nerve. It's very common. Amputations, obviously devastating for a musician. We do see them. I've had several musicians who've had traumatic amputations. Two of the more famous examples of musicians who are my favorite musicians, Rick Allen, who's a drummer for Def Leppard. You've probably all heard of him, who famously lost his arm in an rollover accident on New Year's Eve. And then Jerry Garcia. You guys all know Jerry, right? One of my favorites too. Did you all know that he had an amputated finger? Yeah, so he lost his middle finger in his right hand when he was 4 years old. He was chopping wood with his brother, and he put the wood down and unfortunately his brother wasn't paying, and he lost his finger. They lived in a very rural area, and in fact, those days, the technology to put fingers back on really wasn't even available. So he lost his finger. The reason I put amputations up, obviously it's a significant injury. What I wanted to say was that a lot of the patients who come in who have a finger amputation, and we see a lot of them, they immediately want to have the finger put back on, which is a logical thing. We want to reattach it, which we can do. We have the technology that we can reattach fingers. the part that people don't really tell you is that you can put these fingers back on and you can make it survive, but they don't work very well. Okay? They hurt. They don't move well. They're insensate for the most part. And so, yeah, you have a finger there, but it just gets in the way. It doesn't help you in any way. It's painful. And you're probably not going to be able to use it to play the guitar, play the piano, or the flute, or whatever. So, in fact, a lot of these patients, I say, you're better off not having it put back on. And you're better off going ahead with the amputation. You'll get back to your life sooner. You'll have fewer operations. You'll get back to your instrument sooner, and you can learn to adapt. And so, Rick Allen, I think, is a perfect example. He's gone on to continue to play drums for Def Leppard at a very successful level. He learned how to adapt. Much better off had he ever kept his arm. Had he kept his arm, he wouldn't be a drummer anymore. I'm sure of it. So Jerry's done pretty well, too, making up with his other hand. So he did just fine. Moving on to neurological disorders. I put this is the third category. A very common category of conditions that will affect musicians' hands. Far and away the most common being carpal tunnel syndrome. I'm sure you've all heard of carpal tunnel syndrome. How many of you think you know what carpal tunnel syndrome is? So not a lot, actually, right? You hear that term all the time. But a lot of people don't really know what it is. Carpal tunnel syndrome is actually a pinched nerve. Okay, it's a compressed nerve. And if you look at the picture there's a big nerve that runs down the middle of your forearm called the median nerve, and it gives sensation to your thumb, index, and long finger, and strength to the muscles of your thumb. And in the wrist, it runs through a tight space, which is called the carpal tunnel. And if the nerve gets squeezed, the nerve signals can't get through, and it causes pain. Pain can be severe. It typically causes numbness, tingling, pins and needles in the thumb, index, and long finger, but it can be the whole hand. People say it feels like my whole hand. It tends to bother people at night. People say I'm waking up with numbness in my hand when I'm driving the car, when I'm playing my guitar, and then it goes away, comes and goes. So it has this cyclical thing. Patients will say I have weakness. I don't have the same strength in my hand. I'm dropping coins. I can't button my shirt. And I see this is the most common condition that I treat, carpal tunnel syndrome. And it's very common in activities that are repetitive. So people will say, it's associated with typing. Computer, that's one thing. But playing a musical instrument, definitely associated with that. We see very high rates in musicians. The good news for carpal tunnel syndrome, if it's addressed in a relatively timely manner, it's very treatable. So if you get to it before it gets too severe, you can treat it. If you let it go for too long, it can be irreversible, but that happens over years. The treatments for carpal tunnel, here's another schematic. Again, you can sort of see the nerve coming down the middle there, and this ligament is pressing on the nerve, and that's what causes the compression. When we treat this with surgery, we just cut that band. You can see the serrated dashed line there. We just divide it, and it unpinches the nerve and relieves the symptoms. It's the most common hand operation done in the world. So the treatments for carpal tunnel syndrome, sometimes it's as simple as wearing a splint. So you can see the splint there on the left. By keeping the wrist in the neutral position, it alleviates or decreases the symptoms. Any activities that keep your wrist flexed or extended for an extended period of time, and you can envision how playing instruments can do that, will aggravate the symptoms. They've actually measured the pressure. If you keep your wrist like this for a certain period of time, the pressure in the carpal tunnel goes up. So if you keep it straight, it can really help. So people wear splints at night when they go to bed. They'll wear them when they're working on the computer. It's hard to do with musical instruments. It depends on your instrument, but it can be cumbersome, and but you can use it when you're not playing. It can help alleviate the symptoms. We do cortisone shots. We talked about that. That can be very helpful for carpal tunnel syndrome, but it tends to be temporary. And then we do the surgery, and there's a schematic of the surgery. And again, the surgery is, in my opinion, very safe, very effective, low complication rates, and a good option for people who are symptomatic despite splinting and these other treatment options. So we do a lot of them, and the patients are very appreciative. Carpal tunnel syndrome is far and away the most common nerve compression problem in the hands. Any major nerve in your arm can get compressed, though, and cause symptoms. For example, the funny bone nerve in your elbow can get pinched, and it causes numbness in your small finger and your ring finger. There's another nerve on the back ear, called the radial nerve, that can get pinched. So any of those theoretically can get compressed and can cause symptoms. And these are things we look for when people come in complaining of numbness and pain. But carpal tunnel, far and away the most common. Cubital tunnel, the elbow issue, is second most common. Excuse me. Haven't you guys ever heard of this? Focal dystonia, musician's cramp. Yeah. So this is another thing like repetitive strain injury, in that 10, 15 years ago, again, the diagnosis didn't really exist, or people didn't really know what it was, and it wasn't really talked about. But it's, again, a very real phenomenon. I've seen patients in this musical community suffering from this very condition. Basically what it is patients will come in and they'll say, I've been playing guitar for, 40 years, and all of a sudden, I just can't play the chords the exact same way. I can't finger pick the way I did. It's only with certain things, but I can't do it anymore. It feels like I'm losing my skill. What's happening? And so it's a very specific complaint. That may be their only complaint. And it may be, it's very focal. It's typically one hand. It's only related to very specific tasks. There's not usually numbness or any other neurological symptoms, although there may be, but there's not always. And so it can be hard to lock down. It comes on late. People tend to be in their 30s and 40s rather than, teenagers, 20s. Why that is not really known. It's thought to be an issue with the motor cortex in the brain, so it's a neuromotor condition. It's not a hand disorder. So patients will oftentimes come in my office and they'll say, what's wrong with my hand? And I say, well, you don't need me, you need a neurologist. It's a neurological issue. Although it's primarily, may affect their hand. Writers get it. It was originally known as writer's cramp. There's no cure that we know of, although some people would dispute that, and I'll talk about that in a second. But there's no known definitive cure. People will do therapy, sensory motor re-education, which is a mode of training you to relearn how to use your muscles, use different muscles to compensate. Botox or botulism toxin is a neurotoxin that we use in medicine a lot for it affects how nerves interact with muscles, and you can inject that and it can affect the way muscles work. There's some evidence that it's helpful in this condition, but again, generally not a cure. There's a pretty good article written on this in the New York Times about a year and a half ago called "The Disorder That Stops the Music," about focal dystonia, and it was sort of trying to bring it into sort of the more general, discussion amongst musicians. And but the title is not, in my opinion, that appropriate, because there's a few people who would dispute that there's no cure or that you can't work around this. The person on the left is Glenn Gould. Okay, so Glenn Gould, is a famous Canadian pianist, highly regarded. I don't know a lot about him, but I've been reading about him in the context of this, and apparently he's a pretty interesting guy. I guess a little bit eccentric, you would say. A self-described hypochondriac, I guess. But the subsequent quote that I thought was funny was, just because you're a hypochondriac doesn't mean you're not sick, right? But he complained of these symptoms. He complained of these symptoms all the time. Late in his career, right, exactly. And so there was a guy named Dr. Frank Wilson, who's a neurologist, who wrote a paper on it. I think the title was Glenn Gould's Hand, and basically analyzed it, and his contention was that he had focal dystonia. But in those days, no one knew what it was, and he was poo-pooed that it was all in his head or it was, hypochondriasis. But he probably did. So it's a very, again, one of these conditions that's a very real organic medical problem that's coming more to light. The guy in the middle is, his name is David Leisner. I hope I'm pronouncing it correctly, but he's a classical guitarist, and he has focal dystonia. And his approach, which he has been successful with, he basically contests that there's no cure. And he did sensory motor re-education, learned to use muscles in his upper shoulder girdle and his upper arm to sort of adapt and continue to play the guitar successfully. And he overcame it. And he's helped a lot of people try to do that. The guy all the way over to the right is Billy McLaughlin. He's sort of more of a new age type guitarist, I think. And his approach was more adaptive. He just relearned playing guitar lefty. So he just said, okay, I'm going to turn my guitar around and I'm going to relearn and I'm going to train myself. And now he's touring and performing. So there are ways to adapt to it. But this is a condition you need to be aware of. I've seen it in musicians in Boston. So, interesting condition. You always have to think about cervical issues. Cervical means relating to the neck. All the nerves that feed your hand start in your neck. So they come out of your neck and they run down your arm and they provide sensation and emotion. You can have problems in the neck that can dramatically affect your hand. It can cause numbness, tingling. A slip disc in the neck can press on a nerve and can cause symptoms only in your hand, not even in your neck. So a patient can come in and say, I just have some weakness in my hand, some numbness. I have no other symptoms, and the problem is in their neck. So we always have to consider that as a possibility. Whenever people have neurological symptoms, we have to determine, is the problem really in your hand or is it higher up in your neck? Something to always consider. And this plays a lot, and we're going to get into this a little bit with the Alexander technique in a little while. Postural training, conditioning, things like this to protect your neck are really, really very valuable techniques for musicians. I'm not going to spend too much time on this, but it's something that we have to consider, which is the psychiatric side of hand disorders. There's a long list of sort of fascinating psychiatric conditions that can affect people's hands. Malingering is just, I'm faking it, and there are lots of people who fake it for secondary gain for whatever reason. Somatization is a psychiatric condition basically where patients will transfer significant emotional or psychological stress into a somatic complaint. So they may have gone through a trauma or a very stressful situation, and they'll start presenting as a physical ailment because it's somehow emotionally or psychologically more easy for them to accept that I have an organic, mechanical problem than an emotional or a stressful problem. So clenched fist syndrome is fascinating. There's a picture of it there. I've seen 2 cases of this in the past month. These are people who inexplicably develop a contracture of their hand where they cannot move their fingers to the point where the fingers will dig into their skin, not to be too graphic and cause wound problems. It's primarily a psychiatric disorder. It's not very well understood. The outcomes are poor, and it's generally not responsive to any treatments, therapy, or likewise. Have any of you heard of Munchausen's syndrome? So Munchausen's is an interesting psychiatric condition where people are intentionally harming themselves for secondary gain, and that can present in a lot of different forms. For example, you could be, putting, the wrong medication in your IV. I mean, there's a lot of ways that people present with Munchausen's, but they're essentially hurting themselves intentionally for secondary gain. The most fascinating, and the reason I wanted to put this in here, is Munchausen's by proxy. Munchausen's by proxy is Munchausen's syndrome, but it's a second individual projecting or trying to hurt another party for secondary gain. It's typically a parent to a child, okay? And it can be serious or it can be minor, but I had a case of this recently of a parent. So the parent was the one who suffers from Munchausen by proxy, came in with her daughter, who's a pianist, and said, my daughter has a trigger finger, she needs surgery. And I was like, okay, well, let's talk about it, let's look. So I spoke to her daughter, I said, what's wrong? She said, nothing. I'm fine. Well, does your hand hurt? No. Does it click? No. Can you play piano? Yeah. Are you fine? Yeah. She was fine. Her mother was insistent. No. She has trigger, she needs surgery. Subsequently, went through the whole thing, and turned out that it was Munchausen's by proxy. So you can see these, sort of unusual psychiatric conditions. They're more of interest, I think, than anything else. We don't see them very commonly. But I'm sort of nearing the end at this point. From a prevention perspective, I think the latter part of the program is going to be really useful, and we'll get more into that. But when the questions were posed to me, how do you prevent these things? I mean, a lot of it's common sense, but a lot of it is really, lifestyle choices, okay? And it seems obvious, but I have to drum this home to a lot of my patients. The importance of good nutrition, staying well hydrated. Hydration is critical for hand function. Keeps the tendon sheaths lubricated, keeps your hands moving, keeps your circulation going. It's absolutely critical. It seems stupid, but I can't, exercise conditioning, again, just fatigue levels and postural training is absolutely critical. Getting enough sleep, controlling your stress level. There's no question that these things absolutely directly affect the outcome of my patients and their ability to get back to playing their musicians. Being careful with your equipment, adjusting your your seat level, your guitar strap, these are all techniques that seem obvious, but they're little things that can make a huge difference. The same thing in ergonomics. If someone's in an office, we tell them, you got to change your computer height, you got to get a new keyboard, you got to get a better chair. These little things in isolation sound stupid, but when you add them up, they make an absolutely huge difference. I think that for me, probably the biggest thing that I would mention is what I mentioned earlier, is with hand injuries, playing through pain is not what you want to do. This isn't the NFL. You're not expected to go in and play through pain. And, if you have pain, it needs to be treated. It needs to be evaluated, and you probably need some rest, the other thing is just avoid the landmine with fingers. And I know you all value your hands very much as musicians, but the biggest thing that I've come across where I've had problems with musicians is delay in treatment. They're seen by, even a general orthopedic surgeon, and nothing against general orthopedic surgeons, but they're not hand specialists, and I've seen people mismanaged because they don't get in quickly enough to see the hand specialist, and so they don't start therapy, and now we're in trouble. So, you're better off being conservative and getting these injuries evaluated in a timely manner. If it's nothing, great, but if it is something significant, you can get on it and you'll have a better outcome. So that's a lot to cover, and I think I could probably spend a lot more time on these things in more specifics. We're going to have a question and answer session at the end. I'm going to stick around for that. I don't know how we are on time, if there's time for questions now, or we want to move on to the next.
You should probably hold the questions
Okay.
for the end, unless somebody had a really quick one. So, okay.
I have a really quick question. What do you think about any homeopathic therapies like arnica or anything like that?
So I have a patent answer for that. No. Yes is my short answer. But Western medicine would learn to say, I can't recommend something to you unless I have scientific data to support its efficacy. The problem is with some of these homeopathic methods or, alternative techniques, methods such as acupuncture and stuff, is we just don't have data to say it works. We don't have data to say it doesn't work either, right? So a lot of it does. And so, I generally tell people, look, I can't tell you if it works or it doesn't if I don't have the data. You can certainly look into it if you have a reputable practitioner who knows what they're doing. I send people to acupuncture all the time. I say I don't have proof. But I think it's worth exploring a lot of these avenues because some of them are very helpful.
Quick thing, are doing like wrist exercises with like small weights and like twisting them, is that at all beneficial or is it anyway?
So, two questions. One is for treatment and one is for prevention. So prevention would be a conditioning program. I think that's very good for you. Okay, it maintains strength, flexibility, part of your general conditioning exercise program, depending on what you do. But a conditioning program like that can be very beneficial. Not too heavy weight, 15 to 20 repetitions, not 3 or 4 repetitions. It can be very helpful, very protective. In general, I'm very much in favor of it. In terms of treating the different conditions that we've had, it really depends. There's some cases where I will have people lift weights and do stretching. There's other conditions where you're not doing it for a long time, so it really depends. But from a preventative point of view, absolutely. Yep.
Great. Well, thank you, Dr. Dolan. Dr. Dolan is going to also be involved with the Alexander Technique with Bob later. They're going to have a case study with his guitars here. And so we get to see him at work again, and then a question and answer period at the end.